All right, good afternoon. Welcome to In the Trenches. Today we're going to be talking about chest pain, and I am going to call this Chest Pain 101. And what I want this is really a primer for interns, how to approach chest pain. So let's assume you're evaluating a patient either in the office or in the emergency room or in urgent care, and the patient has chest pain. And there are a lot of different things that cause chest pain. Basically, you have to divide them into two boxes: serious causes and not as serious. So very serious causes. So the three causes that you have to be most concerned about are an acute coronary syndrome, which is either a STEMI, a non-STEMI, or unstable angina. Number two, you have an aortic dissection. Number three, an acute pulmonary embolism. These are the three conditions you really want to rule out. Okay, now there are other causes of chest pain: musculoskeletal pain, esophageal, and it could either be reflux type symptoms or motility disorder, mitral valve prolapse, pericarditis, zoster, herpes zoster. Diagnosis of exclusion would be anxiety. So there are other things that can cause chest pain. So when you're evaluating the patient, like most conditions, the history is the most important thing. And a lot of this has to do with their age and comorbid conditions. Now, if somebody comes in and they're in their 20s and they have no past medical history and they seem very anxious, or if the chest pain is the chest wall is very soft, tender to touch, okay, that's non-cardiac pain. If you have a patient who's older, say it's a man in his 60s with known coronary disease or multiple risk factors, and he has a crushing sensation on his chest, obviously that patient you're going to be more concerned about, and that's a potential emergency, and there's everything in between. Okay, so let's talk about the most serious causes first. Okay, if somebody has an acute coronary syndrome, an acute MI, so patients with the acute MI, unstable angina, and with the advent of troponins, there's really a spectrum of unstable angina, and sometimes their EKGs are normal, but they are leaking troponins to non-STEMI, to STEMI, ST segment elevation MI. Okay, the pain is often substernal. Sometimes they put a fist over their chest, not always. And it feels like a squeezing or a tightness. And sometimes you could ask the patient to talk about their pain and say, I don't have pain, I have a discomfort, I have a squeezing. It's not always a pain. Now, if they had a cardiac event before, you're going to ask them, is this the same type of sensation that you had before? Other symptoms: pain could radiate to the arms, specifically to the left arm, to the jaw, to the neck. They could be short of breath, they could be diaphoretic, and sometimes they could be nauseous. So there are other symptoms. And part of this has to do with the risk stratification. So you want to evaluate the patient's cardiac risk factors, obviously if they have known cardiovascular disease, but if not, are they a diabetic? Do they have high blood pressure? Do they have a lipid disorder? Are they smokers? They have a family history. Now, if it's a younger person, doesn't fit in the demographics, you might want to ask about substance abuse, such as amphetamines or cocaine. But there's three types of angina, and I learned this many moons ago. Stable angina is angina, you get it, you walk like 3 blocks, you get it, you stop, it goes away, you restart, it comes back again. Unstable angina which there's different mechanism. Here are plaque ruptures with the acute cardia. It's new onset angina, angina at rest, or a change in the pattern of the angina. But basically, if they're presenting to you, they have chest pain. Okay, now if somebody has what sounds like chest pain, but it's not typical anginal. It might be like this, but it's at rest. It's not. That's atypical angina, and non-anginal pain is chest pain that doesn't sound like angina. So what you want to do, you want to assess the risk factors, and you want to see if they have a cardiovascular history. Obviously you want to examine them, and then you get an EKG. And, depending what you see on the EKG, and there could be some subtle findings. If somebody's having an ST segment elevation MI, then you're going to expect to see ST segment elevation. And they're normally concave downward. Okay, before you see this, you might actually see inverted T waves. And then it goes to this. Okay, you can see something, forget about the inverted T waves, you can see something called hyperacute T waves, where they're very big, okay, and then the ST segments begin to rise, and then over a period of time, you develop Q waves. Okay, but obviously you're going to get an EKG. Now, if they have a non-STEMI, you might see ST segment depression or T wave inversions. And what's very helpful if you have a prior EKG to look at. Now, a lot of patients could have long-standing hypertension, and they could have LVH on their EKG, and it might be harder to understand. But you have to look at the EKG and the history. Aortic dissection, you don't want to miss. And that's a ripping of the aorta. First of all, that pain comes all of a sudden. Okay, they either have a long-standing history of poorly controlled hypertension, or they have a fibrinolopathy, which a lot of these people are not going to know. They're going to have Marfan syndrome. They're going to have variants of Marfan, something called Loeys-Dietz. There are other fibrinolopathies. They can see Ehlers-Danlos. These are, not that you need to memorize them, but if somebody has features of Marfanoid syndrome, and you could hear maybe a mitral valve prolapse or an aortic insufficiency murmur on them, then you could think about, they'll have a high arch palate, long skinny fingers, increase width to the shoulder width to knee length. Okay, these are things that you could think of. But you might not be able to pick that up on a physical exam. And if there's any concern, classically you check blood pressures. There may or may not be a discrepancy. This pain occurs all of a sudden, and it's ripping and tearing. And if you have a proximal dissection, that's above the great vessels. So here's the aorta, and here's great vessels, brachiocephalic, left common carotid, left subclavian. Occurs here. There's about a 7% per hour mortality unless you deal with it. Rule of thumb, okay, their D-dimers are sky high, and that's actually a blood test you could do. Well, with the D-dimer, you think more pulmonary embolism, but they're very elevated with the aortic dissection. Acute PE. Okay, you can see chest pain with the PE. It's usually not with massive PEs. The chest pain with the PE is normally due to pulmonary infarction, and that's with distal PEs. Okay, and often you may even see a subtle infiltratum chest X-ray, but if it's pleuritic and maybe they're short of breath and maybe they have risk factors for pulmonary embolism, such as post-op or cancer or whatever, it's something you have to think of. And then you're going to risk stratify them, evaluate them. These people, you would usually get a D-dimer, and then you get CTA and evaluate them for pulmonary embolism. This is pleuritic. This is a different type of pain. So what you need for these serious things, the history is the most important thing. You have to talk to the patient. Now, if you're dealing with potentially emergent situations, then you don't have a lot of time to talk to them. You have to kind of figure out in your mind what this might be and do the diagnostic test. Now, if it's an acute cardiac syndrome, depending on what medicines they're on, You may be placing them on IV heparin. You're going to be calling cardiology, especially if it's an ST elevation MI, because they're going to need intervention. And if it's a non-ST segment elevation MI, they might need intervention at that moment, but they may need it soon. They're going to need to be watched very closely, and they may need IV nitroglycerin. They could possibly need beta blockade. Okay, but they're going to go in one box. Somebody you suspect has an acute dissection. Normally, the way you're going to do this is do, a CT aortogram on these patients. Sometimes they'll do a 2D echo. An MRI will take more time to do, and if this is acute, most likely you're going to do a CTA, and if there's a contraindication, then they're going to do an echo or transesophageal echo to evaluate this. And then this is usually they're going to have to put them on IV medication to control the blood pressure, but you're going to get thoracic surgery involved with repairing the aneurysm, especially if it's a proximal aneurysm. If this is a pulmonary embolism, okay, you're going to anticoagulate them, and you're going to put them in a risk categorization. You either have high risk, intermediate risk, or low risk. With chest pain, they're usually low risk, but they're going to need to be anticoagulated. Now, talking about the other causes, and theoretically in here we also have pneumonia, pneumothorax. So, if somebody's coming in and they have chest pain and they're coughing and they have a fever and they have an infiltrate, it's pneumonia. Pneumothorax obviously is not as common. You're going to diagnose that with chest pain, but if they developed acute pleuritic chest pain, you're going to image them. Viral pleurisy would also come off here. Herpes zoster, I'm putting this here because I've seen a few times in my career patients come in with chest pain, and they're doing a cardiac workup on the individual, and you look at them and they have a big zoster rash, D10 dermatome, and that's what's causing the pain. So you just want to look at that. Pericarditis could sometimes get confused with MI or cardiovascular, and they have EKG abnormalities. Now this is viral, and the pain can be pleuritic. It's relieved by sitting up, and you may have pleural disease also. And the classic EKG finding, here you have ST segment elevations, but the ST segment elevations are concave up, not concave down. And you could also have PR wave depression with the ST elevator. Then they normalize, then you can get T wave inversions, and that normalizes. And normally you see this in most leads. The PR depression is what's known as Spodek sign. Okay, mitral valve prolapse, very non-specific, and you'd have to rule out everything and do an echo. Once in a while they can do that. Esophageal causes, somebody gives the symptoms consistent with reflux, it's heartburn. Once in a while angina can present like that, and if you ruled out the serious things, then you have to think of these. Musculoskeletal, somebody has chest pain, okay, and you press them, does this hurt? Yes, it's a musculoskeletal. Okay, even if somebody with established coronary disease can still have musculoskeletal. And frankly, if there's a syndrome, somebody accidentally hit me with a door and now it hurts here. Okay, this is musculoskeletal pain. But if it's tender, it's musculoskeletal. It's called Tietschke's syndrome. But that's easy. So this is 101. This is an approach to chest pain. What I want to do is debrief on all that. So if it's cardiac, the history, the risk factors, you're going to use logic. Once in a while, you'll see a young person with cardiac, with an acute MI. You can see a woman who has spontaneous coronary artery dissection. So you can't 100% say just because this is someone young, like a young woman, it's not cardiac. You're going to have less of suspicion, but you're going to get an EKG, especially if the history goes along with this. Aortic dissection, not as common, but in your careers, you will see this. You need to know how to recognize it. What you're going to do, they're going to be, you're going to decrease DP, DT over the aorta. You're going to need to slow their heart rate with beta blockers, have them fully beta blocked, and then give them medicine to lower their blood pressure. And if somebody has a pulmonary embolism, that's a different type of chest pain. Now, something else you can do, somebody with chest pain, okay, you might want to give them sublingual nitroglycerin. And this is very basic. And kind of, if it makes them better, it can make you think maybe it's angina. And the mechanism it does that, it's going to decrease the MVO2, the myocardial O2 demand. It's going to do that. Nitroglycerin is a vasodilator. It's going to shrink the heart. It's going to lower the radius of the heart. And it's going to decrease the oxygen requirement. If somebody's having an MI and they're having pain, nitroglycerin will not lower the pain for the MI. The only thing that will do that is morphine. Nitroglycerin will relieve ischemia if there's subsequent ischemia. Now, the world has changed a lot. Normally, when these patients are identified, they're going to interventional cardiology as soon as possible. But they often require nitroglycerin. They may need IV nitroglycerin, depending if their blood pressure can tolerate it. And they'll also need beta blockade unless they're, if they're in pulmonary heart failure, you're not giving them beta blockade up front. As a whole, one thing to remember, the prognosis with an acute MI is related to the size of the MI, and the quicker you intervene, the smaller the MI will be, and the better prognosis the patient will have. And with all this, I'm going to stop right now. We're in the trenches, and this is Chest Pain 101. Thank you.